So talking about ankle sprains, we know that ankle injuries are one of the most common injuries that we see in our sports practice, and pretty much in the orthopedic practice. 2.5 per 1,000 person years, 23,000 ankle injuries a day in the United States. Up to 40% of all basketball injuries are the most common injury in volleyball and one of the leading causes of loss in American football. So in terms of the epidemiology, lateral ankle ligament applies to about 90% of these ligamentous injuries, but don't forget the medial side as well. And you can also have multi-directional ankle instability as well. 77% of the English Premier League players were on the lateral side. So talk about the lateral ankle sprain a little bit here in the anatomy. So the ATFL, as we know, is restricting the internal rotation of the talus. So when you're testing it, it's the anterior drawer with internal rotation, whereas the anterior drawer with external rotation is testing the medial side of the ligaments here. The ATFL is elongated in plantar flexion, and it's a primary restraint, as I mentioned, to inversion, internal rotation, and anterior drawer. It has greater strain than the CFL. On the CFL, we see here in the anatomy, it prevents hindfoot adduction. It's different than the ATFL, and elongates in dorsiflexion as opposed to plantar flexion. And it attaches from the fibular attachment down to the calcaneal attachment, just from the posterior point of the perineal tubercle here. The primary restraint to inversion in neutral and dorsiflexion, and the load of failure is about 350 newtons. So when you think about ankle instability here, the perineal muscle is also important, and also not forget. It's the dynamic stabilizer of the ankle. You have weakness and spasm can also accompany chronic ankle instability. So oftentimes you'll see accompanying perineal tenosynovitis with lateral retromalleolar pain. So it's really important as part of the primary rehab is working on both perineal strengthening as well as ankle stabilization, along with kinetic chain strengthening more proximally. As we move to the surgical algorithm here in the ankle ligament instability, of course, thinking about it non-operatively and then moving on to surgical,